I am really excited to have Dr. Brittany Lamb back. She has been one of our most popular guests on these discussions, and she has put together a presentation today and on goals of care, which is something that we probably talk about every single week. And so I am delighted that she's done this because I think it's going to be helpful to a lot of people. But I'm also delighted that she's here and available to share these resources with our community and engage in one of our interactive discussions. So Dr. Lamb, welcome. Really glad to have you again.
Hey, thanks so much for having me. I'm so excited to be here. I really appreciate the opportunity to talk about this. Goals of care is something I care a lot about. So thanks for having me.
No, I love it. And folks, normally I love having this banter back and forth with our panel member, but because Dr. Lamb has so much content, and I saw her slide deck, she's got a slide where she's going to talk a little bit about her background. I don't want to risk her having to repeat herself. And so what I'm going to do is duck behind the curtain, and Dr. Lamb, you can share your screen when you're ready, but I want to remind everybody in the audience to use chat and use Q&A. So if there's anything that Dr. Lamb is saying that, or if you've got a question, type it on in there. Glad to see that everybody is using chat. We got Courtney, Ashley, Curtis. Feel free to use that to introduce yourself, ask a question, or what have you. So let's I'm gonna hit the mute button on my end, Dr. Lamb, and let you take it away.
Okay, all right. Yeah, thank you for letting me put together this slide deck. It will help me keep kind of organized, and we can hopefully have a good talk here. And yes, please ask questions. I may take a few pauses in this so we can kind of catch up. But so I'm here today to talk about the importance of defining your goals of care. So let's go through this. Who am I? My name is Brittany Lamb. I'm an ER doctor. So I work full-time night shifts. I work here locally in the Northern Virginia area. I'm not here on behalf of my hospital, but why I'm here today is really the more important part of things. And so I want to talk about goals of care with you all because I feel like this is going to save you time and it's going to improve your interactions with the healthcare community, no matter if that's in an office setting or if that's in the ER or the hospital. So it's really important, and I think it's something that gets very, very much overlooked. And I found that it's pretty foundational in making medical decisions. And so it can only help you. And so I'm gonna teach you how I teach my patients about goals of care live in the emergency department. And I'm hoping that my goal today with this talk is to just kind of spread some thought and awareness and maybe have you seeing things in a different way. So when I say goals of care, what exactly do I mean by that? And I think that when we're talking about our care goals in general, there can be a lot of things that might spark thoughts for you, like, where someone lives, who takes care of them, those types of things. But what I'm talking about is specifically when it comes to their medical decisions. So when I'm talking about goals of care, I'm talking about medical decision making. And part of that is actually going to look and search for medical problems, and then what we do when we find them, how we treat them. There are 3 overarching goals of care categories that I teach and that we all fall into. And so I'm going to talk a little bit about some other things, and then we'll get into each of those goals of care categories. So I don't think that we talk about goals of care enough. And I think there's one big reason why, and it's because as we move through life, our goals of care are known. So they're implied, like you don't have to speak them out loud. We all know that we all value living. We want to live and we want to have quality of life. And so I think for the majority of our life, that is our goal. And only when certain things start to happen, one of those things being aging, do we start to think, maybe we need to rethink this concept. Like maybe we actually need to talk about this and what's important to people. So I think that the medical and healthcare system is set up to do things to people to keep them alive for so long that I think that we've lost sight of thinking big picture and considering what we're doing. Like, just because we can do things, you know, should we do them? Like, and so that I think that this is the big reason why we don't talk about this often. So what we do now is we wait. So we talk about goals of care and what's important to people when we kind of have our backs against the wall a little bit. And I'm talking about healthcare professionals, so doctors, nurses, and then also with patients, you know. So if someone's really sick in the ICU and we recognize that, we're doing a lot of things, we're adding on treatment, we're adding on layers of care, and things aren't going in the right direction. Or maybe we're really concerned that this person might have a worse quality of life than what they would find acceptable if they do survive. And that's when we go to families and say, hey, we need to have a goals of care discussion. You know, I put the picture of the heart there because a lot of people who are aging and a lot of people in general have underlying medical issues and conditions that affect their quality of life. Things like congestive heart failure, CHF, COPD. So this is issue with the lungs that affect the way that we live every day. And what we oftentimes will bring up goals of care when someone has been in the hospital, that keeps entering the hospital system. So, you know, I have patients that come into the hospital and are admitted to the hospital once a month, once every couple of months for multiple years. And so that sometimes is when we talk about goals of care. Another time that we wait is also when people have cancer. And so that's what the ribbon represents is, you know, and this happens in people who are younger. I mean, goals of care discussions happen in people who are not aging. You know, my father, I had a goals of care discussion with him. He passed away when he was 52 years old of a brain cancer. So sometimes this happens sooner, but again, we oftentimes wait too long until we've realized that, you know, our treatments and what we're doing to try to cure this person of cancer or treat their cancer may not be working. And that's when we talk about it. I think that, you know, for me in medicine, it's almost cringeworthy to have to walk into a room and talk about this when I feel like I'm coming in there delivering bad news. Like, I'm bringing it up now because we need to make decisions and it's important and it could affect someone's quality of life and how they continue living, but also like what medical decisions we make. And so I think we're making a mistake. I think that we need to do this work earlier on. So talking about these situations in times of crisis and stress, and we're identifying what's important to people sooner than that. Let me just say a few things about why we should not avoid talking about goals of care and defining what they are for ourselves, for the people that we speak on behalf of, and for our clients, for people that we're advocating for who are aging. So the number one reason is that we are all at risk of not being able to speak for ourselves when we get sick. So I'm at risk of this. You're at risk of it. We all are. But as we age, we have a higher risk of being sick and not being able to speak for ourselves. And I'm talking about people that have the ability to make their own decisions, who live completely independently, who get sick and then they cannot speak for themselves because they're too ill. It is not an if situation, it's a win situation. So it's a win, not an if situation for people who are aging, that at some point they're like highly to have a situation in which they cannot speak for themselves. So by not defining goals of care and not communicating that with your care team and with your family, the people who will be stepping in and speaking for you, you run the risk of having too much care or too little care that you would not want, okay? Care that you would not choose for yourselves. So this is the number one reason. The other kind of huge reason is like a win-win for me too, is that, you know, medical professionals now are really under a lot of pressure and strapped for time. You know, you think about the last time you went to your doctor's office and had a visit with them and it was 15 minutes. The time that you have for healthcare professionals, I think, can be maximized if you know your goals of care. If you know your goals of care, or you know the goals of care for the person that you're speaking on behalf of, then when you are in the situation with a medical professional where you're having to make a decision and you're having a discussion, you can talk about how the different options for what you might do might affect that person, what their future looks like, and have a better discussion about the now and the going forward, instead of trying to get on the same page about where we're at and what our goals are. And I do think that some of this needs to be discussed with medical professionals, but I'm going to arm you with some information so that you're better able to have this conversation. I cannot stress enough like how important it is to know your overall goals, especially when you're in an emergency situation. It's time saving, and it can really help make sure that we're all on the same page. So it improves communication with healthcare staff to have these things defined. And it tells us, the reason why is it because it helps us know which way to go. If I know someone, wants to focus on care that provides comfort, then I'm going to offer them vastly different treatment options than someone who I know wants everything done to keep them alive. And I might say to that person, like, these would be the options if we were going to do everything, but I know that your goal is to do this. And so this is what I would recommend for you. So anyway, there's lots of benefits to this, but these are the main things that I think of. So I want us to do better, and I want to talk about how we can actually, like, a little bit of a process that we can go through to kind of start thinking about and defining our goals of care. And I just wanted to pause here and see if there is anyone I can keep going, or if there's any comments or questions or anything.
No, thanks for doing that. I think it all sounds great. Just keep on rolling, but this is a great reminder for folks. If you've got something, if you've got a comment, an experience, anything like that, throw it into chat or Q&A, and we'll make sure to address it.
All right. So the first thing that I think, what I recommend that people do when we're thinking about goals of care, and this is kind of what I do in the emergency department with patients and families. And I try to do this when I have time, even when we don't need to make these decisions right now, because I care so much about this and I like to plant seeds in people's minds. But the most important thing that we do first is we figure out if the person values quality of life. So does the person have a value towards quality of life? Do they care about that? And then we need to think about, do they value quality of life, or do they value length of life? And I know that that can be more, like, which one do they value more? There's a balance there. So I know that that can sound a little daunting. Like, of course we value quality of life and length of life. But the thing is, at different stages in life, you may value one of these more than the other. So for example, for me personally, I value my length of life very, very much, right? I have a great quality of life. I'm willing to go full court press to keep me alive, because I'm willing to sacrifice some of my quality of life to stay alive. I very much value quality of life too. So if I kind of had a balance in this, trying to think about it, I value my length of life a lot, but I value my quality of life almost as much as my length of life. And like I said, I'm personally willing to sacrifice quality of life to continue living. But as we age, a lot of people start to focus more on quality of life and less on length of life. And their balance can look more like this: quality here and length second. Or maybe their quality of life is not great, and so they value that much more in protecting it, and they value their length of life less. So we need to determine whether or not someone has a value of quality of life, because I'll tell you, there are also people who value the length of their life over everything. They want to continue living, and they want everything done to continue living no matter what. And that's their choice and their preference and their value. Their value is on length of life. So we need to know, does the person have some sort of value of quality, and what is that in relation to length of life? And then the second step that we need to do is actually think about, what does quality of life mean to that person? What does it mean to you? This is subjective, right? Like, this is individualized. This depends on you as an individual, what living means to you. And that usually changes over time. We know that someone's quality of life typically changes over time as well. Like, what gives someone quality of life changes. So I encourage people to have conversations like this within their family. I think this is much more approachable of a conversation than, do you want to go on a ventilator? Do you want to be in the ICU? Do you want to have CPR? You know, like, this is, if you understand this about your family members, about yourself, and you can communicate it to other people, knowing this part of your life and what your values are, and what living means to you, it can help people make medical decisions on your behalf. And I recommend that people not only talk about these things, but also write them down. It's really important that you document this, because then you can go back to it as time goes on. So what I'll tell you is that when you're advocating for someone who is sick, who is aging, and as their quality of life gets worse slowly over time, typically, or with different medical issues that come up, it can become somewhat normalized to see that person have a change in their quality of life gradually. And if you don't have this stuff written down, something that you can go back to and reference, you may kind of lose sight of the big picture. That's one reason why it's important to record it. Another reason is that the person's goals of care might change based on what living means to them and what their current quality of life is like. So these are just some questions that I recommend people consider with like these icebreaker kind of conversations. So what does quality of life mean to you? I asked my grandmother this question not that long ago, and it didn't shock me at all, but it allowed me to dig deeper into some things with her. So she told me, just to share with you all, she told me she wants to be able to have conversations and recognize her family. She wants to be able to enjoy a good meal, you know, and a glass of wine, she said. And she wants to live and function as independently as she possibly can. And then when I dug deeper with her on that, you know, I got into it a little bit more, and I asked her, well, what if you're not able to function independently and you have to depend on other people to help care for you? What would you be okay with, and what would you not be okay with? And she basically came to the realization that she would not be okay if with continuing to prolong, essentially. She wouldn't consider that she had quality of life if she had to have complete dependence upon other people for her care, and she wasn't able to communicate with them. So she wasn't able to say, that hurts, that's too cold, that's too hot, or express gratitude, be able to tell that person, thank you for taking care of me, thank you for being here, like, I appreciate you. That matters to her. I think that matters to a lot of people. So I like that example, and I got that out of her by asking her what quality of life means to her, because she's 83 years old. She lives independently, and I know I'm going to be involved with helping make her medical decisions, because I'm a doctor and I'm an ER doctor. So it's what I do every day. Anyway, I think that's a good question to ask. And I also think that if you ask people if they feel like there's a difference between living and being alive, I think that can kind of open the doors for conversation. I would like to plug the Conversation Project here. It's a wonderful website. I think that there's a lot of tools on there for having conversations like this. And I think having these talks and recording what you get out of them, doing it on your own, I think is important. And then this way you can communicate this with your family. It will only serve you. It will only serve to benefit you, I feel like, in the long run, when we're talking about medical decision making and goals of care. All right. And number 3, so first off, just to like recap, so we're going to figure out quality of life versus length of life. Does the person care about quality of life, and do they value that, or do they value length of life? Where are they at right now? And then what do they think about their quality of life? What does that mean to them? What does living mean to them? And then you're going to choose a goal of care category. And these are the categories that I teach. And typically a lot of people, if they value quality of life, they're going to go from most aggressive treatment to least aggressive treatment. And so that's the order in which I kind of teach this. And so the first goal of care category is full treatment. And we're going to talk about each of these. Okay. First category is full treatment. Second is some but not all treatment. And then the third category is comfort focused treatment. Okay. So I'll just pause for a second again and see if we want to talk about anything.
Yeah, let me just glance at some of the comments and questions that come in. Well, here, okay, so Ashley asks, how does the social worker play a role in the goals of care discussion with the provider? Often they are overwhelmed and overworked. So I think we're probably, what Ashley is referring to and that you can comment on too, is that hospital social worker transitioning to a someone out of the hospital, perhaps.
Well, with that comment, that makes me think that they're trying to help define goals of care, but they need the medical provider to kind of weigh in and help them with that. And the medical provider is too busy and overworked. So and I think that's real, like that's a real problem. And a huge part of the reason why this work is challenging. And so personally, what I think a solution to that is arming people with information. And so creating online education for patients to consume on their own time that then they can use this information to apply to their own individual situations so that they show up to have a conversation with the social worker ready. And so, I mean, a lot of this is in prevention. And so I guess like if you have people that are entering the hospital system that are getting discharged, and we know that that person is at risk of requiring readmission and continuing to use hospital care for whatever reason, like perhaps we have educational programming that we can refer that family and that patient to that they can consume so that when they show back up, they're, better able to make an informed choice. And that's like kind of where my brain goes. I'm happy to throw that around with other people, but that's why I've decided to come online and do online education like this. That's why I built my course for family members of people living with dementia.
Great. Yeah, and this is we're all in this community together. So that was a great question, Ashley, and that's exactly what she was alluding to. And great response. But folks, feel free, if you've got ideas that might help Ashley, let's throw them into chat. And I'm going to do just one other question, and then we promise we'll get through everything else as we take breaks and throughout. And that's Curtis says, do you find people are focusing on quantity of life based on fear? I've experienced enough to have had discussions with doctors that are amazed I recognize my timeline is short and I'm okay with that. Yeah, I guess, I think it is probably these goals of care discussion. It's really getting inside what makes us all tick. And some of it is fear. I mean, fear of death is a real thing.
Oh yeah, 100%. I mean, and I think part of it is that when we diagnose people with medical problems, because we're so limited in the time that we have with patients, we diagnose them, and then when they come back, we're just like, putting a Band-Aid on it and managing it, right? Like we're trying to prevent it from getting worse, but we don't actually always have the time to educate people about the actual disease process and kind of what it can look like as a person ages and how it can affect their quality of life, so that they can start to learn about this stuff ahead of time. And so I find a lot of people that have been diagnosed with really significant medical problems not realizing that that problem is never going to go away, that they'll live with it, and that it is likely that it will affect their quality of life and may play a role in how they pass away. And I think that there's a fear from patients, but there's also a fear from the providers. So, I mean, people are worried that they may say the wrong thing, that they may upset someone, that they may, misjudge their values or their culture even. I mean, so it's a very sensitive area. And so my solution to it is to put this stuff online, and then for the people who are interested in it to come and find me and let me help them. But yeah, I think that I think there is a lot of fear, and I think that's perfectly normal.
Great. All right. Well, I'll let you get back to this, and keep the questions, comments coming. We'll address any that haven't been answered.
Okay. So I'm just going to go through the goals of care categories for you all and kind of talk about them big picture. So with full treatment, I mean, this is our goal of care for most of us for most of our lives. So from the time that you're born, basically your goal of care is to live, right? And so people in this treatment category are okay with having every medical intervention, treatment, surgery, procedure, hospitalization, all of it. because their goal is to continue living. And this is the default in medicine. So this is what we do if we're not told to otherwise. So unless you tell us otherwise, this is what you get. It's the default, right? And I want to plug that quality of life. People in this goal of care category can still have a very high value of quality of life, which is why it's so important that we document what that means to us, so that as our quality of life changes and likely gets a little bit worse over time as we age, that we can then change our goal of care. And so it's really important that if someone values quality of life, that we consider that for them going forward in the future. So just because you're full treatment now doesn't mean that you have to be always, but you can be always if that's what you want to do. I would just say, make sure that you're informed about the choices that you're making. Okay, this is a huge goal of care category, especially for people who are aging. So some, but not all. This is what it sounds like. It's some care, but not all care. So it's very individualized. And I'm going to talk a little bit about my work here in a second. So people in this group value quality of life a lot, and they value it just a little bit more than they value the length of their life. The first thing that someone would kind of give up from a medical standpoint, a medical treatment they would decide that they don't want anymore, that would make them not full treatment and would make them some but not all, is CPR. Okay, so if somebody does not want to have cardiopulmonary resuscitation, which is a bundle of care that we use when someone is dying. So when someone has lost their pulse and they're not breathing, that is when we do CPR. And CPR includes 4 things. It includes controlling someone's airway, however we're going to do that, supporting their breathing. Oftentimes that's putting them on a machine, or it's a little bit complicated. We intubate them, right? So we put a tube down their throat, and then we can bag them, give them oxygen, and exchange oxygen and carbon dioxide. So control of someone's airway and breathing is one part of CPR. The other part that you see is chest compressions. And then we have medications that we can give. And sometimes in some situations, we can shock people. So I just wanted to briefly talk about like the bundle and what's included in CPR, but that's the one thing that someone would go from full treatment into this group if they did not want to have CPR anymore. And there's a lot of education that's needed to be done on CPR with lay people and with people who don't have a medical background, because as we age and as we pick up medical problems, especially issues with the heart, the lungs, the kidneys, CPR becomes less effective. It's less effective when we have to do it outside of the hospital. It works better in the hospital because we're immediately there. And there's some other things that people need to learn about, in order to decide whether or not they would want to have CPR. So that's a whole talk in and of itself. But that's the first thing that someone would say, okay, I don't want CPR anymore. So now you're some but not all. But that staircase there is representative of a huge group of people. So you may say, I don't want to have CPR, but I want everything else done. So, and that's very reasonable. I don't want to have CPR if I'm not breathing and I don't have a pulse and I'm actively dying. But before that happens, I want you to try to save my life, right? And I want to go to the ICU. I'm fine with going on the ventilator. That's fine with me. So that's one group of people. Then inside of this same category, we have people who are willing to go to the intensive care unit, to have care that prolongs their life, that's considered aggressive, even to be put on a ventilator, but they only want to do that for a certain amount of time. So they have like a time limit on it. They're saying, people will say, I'm okay with trialing this care, but if I'm not getting better, then we need to look at things again. And maybe my goals of care need to be changed. Then there are people inside of this group that would want care that prolongs their life in the ICU, to be on a ventilator, all the things in certain situations. So for example, if someone has an infection, they may say, I want to go full court press. I want you to do everything you can, all the care if I have an infection. But if that's not the situation and I have underlying heart or lung disease, and that we know that is not going to get better over time, that's going to get worse. I don't want to do that. I don't want to go full court press. I want less aggressive care in that situation. And then there are some people who would be okay with life prolonging care, but not if it was to cause them discomfort, if they don't want to go on the ventilator ever, they would also fall in this group. There's a huge group of people that would fall in here, and they need individualized plans, individualized decision plans, which is something that I believe that we can do this now. I believe that we can create plans for people as individuals as they age about what medical decisions they may or may not want based on what they're at risk for. So we know the medical issues that people have now and what they've had in the past. We know what those things put them at risk for, what emergencies, what big decisions their family or they are likely to have to face. And I believe that people are capable of learning in advance and kind of thinking through these things, talking with their family and discussing what they would want to do. And I think that this is a better tool, this individualized plan, than advanced directives. And I think advanced directives are tools, but they are not a plan. So I think we need to move to doing individualized decision plans for people who are aging. And so that's what I do for family members of people who are living with dementia. Is I help them create a plan for their person based on the decisions that they're most likely to have to make. So this is what I would love to see happen in the future. I think we're going to need to have more buy-in from doctors to accomplish this. But I think we can disseminate information and general information and medical knowledge to people, and then they can use that with their medical care teams to make the best decisions for themselves for now, and then thinking about their future. So the third goal of care is comfort. And I think there's a lot of misconceptions with this goal of care. These people value quality of life over length of life, 100%. And they would benefit from having medical order forms like the do not resuscitate form and the pulsed form, which I'm going to talk a little bit about in a few minutes. But there's a lot of misconceptions here in this goal of care category. And what I find people thinking this is that we're not going to treat people, that we're not going to provide them care, that we're just going to leave them. And that's not true. People who want to focus their care on comfort, everything that we offer them should have the primary intention of protecting their quality of life and providing comfort. So when someone is coming and asking if the person wants to be admitted to the hospital, or they want to have a procedure or a new medicine or some sort of treatment, the question that you would ask is, well, what's the intention behind this treatment, this medication, this procedure? Is it to provide comfort, or is it to prolong life? And so like one of the examples that I use is, say someone who is walking around falls and breaks their hip. Okay, and their goal of care is comfort. They have a quality of life that they would find is not acceptable to them anymore, or is such that they would not want their life prolonged anymore by medical treatment, by aggressive medical treatment. But this person was walking, okay, and then they fall and break their hip. So it can be comfort care to fix that person's hip with surgery, even though that may prolong their life, and it may also make their life much more complicated. And we all know there's complications from these types of surgeries. But, weighing out that choice, that can be something that can happen for someone who has a goal of care of comfort, because we know that is pain control. Like, that is quality of life, allowing this person to maybe continue to walk, knowing that, of course, we need to apply the risk and the benefits for that person as an individual. But that's one of the biggest misconceptions that I see with comfort focused care. So I wanted to see, before I keep going, Steve, if there was anybody else that had thoughts or questions.
Yeah, and I want to make sure that we've got an audience on LinkedIn, and Lisa says, so basically this is advanced care planning, and I guess to Lisa, this is an approach to advanced care planning, but then she says, so why is it so difficult to get a palliative care consult? And I'm not sure where you are, Lisa, geographically, but perhaps somebody in the audience could help you with that. But what are your thoughts on palliative care consults?
Yeah, I'm glad that you asked that question. I have a slide on that in this talk. So palliative care is underused. And part of it is because doctors don't know what it is. They don't know the benefits of it. And so, they don't recommend it to patients, which is a mistake. And so we just need more education about the difference between palliative care and hospice care. And we need to make it, I think, just less scary and more approachable and more transparent for providers, and also for patients.
Whoops, great. Okay. I promise we'll get to all the comments, but I wanted to address Kathleen's because
Yeah.
this is our number one topic on this platform is solo aging. Okay. And,
Oh, yeah.
and Kathleen says, I'm listening to this. I hear frequent mentions of family, but what about those of us who are solo agers? So I just want to make sure that I stick that not only in the back of our minds up here,
Yeah.
but on everybody's minds, and the fact that most of us, well, there are people that are identifying themselves as solo agers, and then there's those of us who are out there that may someday be solo agers because
Yeah, I
our
may be
spouse
one.
dies.
Yeah. No, I
So,
think I'm glad that you mentioned that. The work that I'm doing online is it's for family members of people living with dementia. So that's why I'm coming at it from this angle, but it's really important. It's just as important for solo agers as it is for everyone else. And I think that in these situations where we may wind up not having family to advocate for us, it just becomes more and more important to document what is important to us and to disseminate that information to any medical team that could be taking care of us. And I think that as we work in this space and we have more and more people in these situations, I think that we're going to come up with solutions to this. I think having document sharing and knowing where to look for people's documents is a big deal. Off the top of my head, I know there's a national registry for advanced directives, but having these kind of written plans based on your goals of care that you write in your own words that you're able to upload, into some sort of platform or database, or that your doctor knows where it is, you have it on file with the hospital. I think stuff like this is going to have to change over time because we're going to have people in situations like that more and more who want to stay, who want to speak for themselves ahead of time and want their care wishes and values and preferences to be followed. And so these tools need to be developed. And, other than putting that stuff in a registry now, and making sure you have a contact, you need to have a contact for the hospital, because I need to know who I'm going to call. If I don't have any paperwork that's on file for you, I need a person that I can call. So creating some sort of network of people who are willing to speak on your behalf. Even as a solo ager, I would hope that there's someone, a friend, a cousin, a niece, a nephew. It doesn't have to be a family member that makes decisions on your behalf. It can be any person. That was a long answer.
yeah, no, that's great. More questions are coming in, but let's get through,
Okay.
and then we can address those.
Okay, so I'm gonna try to go a little bit faster, but so how do we know when the goal of care needs to change? This is all based on how someone is doing in their quality of life and what living means to them. I teach this concept of tipping points, and I encourage people to kind of think through this, when would they want less aggressive care based on what's going on in their quality of life. And I write about this on my blog, so you can read more of my thoughts there if you're interested. So who do you need to tell? This kind of goes back to what you were just talking about. You need to tell the medical community what your goals of care are. So we need to know what you're thinking, and then we can document it. I can write in my notes, I can write in my hospital system, at least I'm able to write a specific note about goals of care and about advanced care planning, so that people can read that the next time someone's in the hospital. When you're conscious and even if you're super sick, you can tell me, hey, look, I want some things, but not all things. I want to focus my care on comfort, or I want full court press until this happens. We need to be more open about these conversations. And we need to do that. Medical professionals need to do that also. But we need you to prompt us because we don't know where you're at. And so if you've picked your goal of care and you know what it is, like, which is what I want everyone to do, then you come at us with it and we're all going to be better on the same page. And then when it comes to family, friends, whoever is going to speak on behalf of you, they need to know. And one thing I'll say about families is that you may name a medical decision maker in a legal document, but like make sure the rest of your family that is going to weigh in and help that person and be involved in some way, make sure that they're all on the same page as much as possible, because people second guess themselves when they make decisions on behalf of other people. So, and I see this all the time in families. So try to get everybody aware of your goals, even if you're not declaring, one or more people in your family as your decision maker. And then briefly, I wanted to talk about the medical order forms. So in Maryland, so we're in like the DC metro area. And so I'm doing this a little bit specific on Maryland and Virginia. So in the Some But Not All group, I told you all that I think that this is the place where someone would not want to have CPR anymore. But there's this huge spectrum of how aggressive the person's care would be otherwise. And when I want to tell people that medical professionals have a bias towards people that have do not resuscitate order forms, and that bias is towards less care. So you need to know this when you go to do a do not resuscitate form on behalf of yourself or someone else. Like, you need to have a conversation about your overall goals if you do not want to have CPR, and make sure that it's well communicated that you want everything else done other than CPR, because the do not resuscitate order form should only go into effect when someone does not have a pulse and is not breathing. Okay, so, and I'm actually going to build out training on the do not resuscitate form for the state of Virginia and our post form as well, because I want to educate more people on this. So I'm going to create training on this probably sometime in March. I'll get it out and I'll give it out to Steve and the network, and you guys can disseminate it and give me feedback and whatever. But so in Virginia, we have two forms, the do not resuscitate and the post form. The post form is an offshoot of the pulsed form, which is physician orders for life-sustaining treatment. In Maryland, they've rolled these two forms into one form. So there's no do not resuscitate in Maryland. It's just the Maryland orders for life-sustaining treatment. And basically, it's more care choices than just CPR, okay? And that's what the post form is too. It's more care choices than just CPR. And so people who are some but not all should consider having a do not resuscitate form, and look at the post offshoot that you have in your state. Look at it and see whether or not it would apply to your situation or whoever you're advocating for situation. People in the comfort care group, that goal of care group, should have a do not resuscitate form, and they should also have definitely at least looked at the post offshoot form for their state and likely fill that out as well. And medical order forms, just to define them very quickly, I'm sorry I didn't say this, is that these are forms that are signed by a medical professional with either the patient or the person who's making decisions on their behalf. And it is an order because every medical person that comes after, paramedics, nurses, doctors, is supposed to follow that form when they have that document in hand. It's an order. It's just like ordering a medication. Like, I would order an EKG or a medication in the emergency department, and then the nurse would give it. This is a paper order form. So that's all I'm going to say about that. And then my last thoughts about, I'm glad that you asked that question about palliative care. So what about hospice and palliative care? First off, we're not using them enough. We need to use them more. These are valuable people. They're experts. They can help have goals of care conversations. They can help make sure that the care someone receives is what they would want. They look at medications. They hook people up to resources in their community. They're literal experts in the conditions that people have. So underused, undervalued. And this is what I recommend definitely for people living with dementia, but people who have a chronic underlying medical condition that we know is going to affect their quality of life over time. and it will likely get worse, over time. So for people that have a diagnosis of a chronic condition like that, palliative care is a wonderful asset, and we should be referring to them more. So people in the full treatment group and the some but not all group would qualify and be good candidates in a lot of cases for palliative care, because palliative care allows for treatment that prolongs life. And that's the biggest difference between that and hospice care. Hospice care is focused on keeping people out of the hospital. And what do we do in the not saying they can't come to the hospital, they can, that's not what I'm saying, but it's focused on trying to keep that person comfortable and to provide them services where they are living that are focused on comfort. So the goal of care in people who are on hospice should not be to prolong life. It should be to first provide comfort. And so people in the comfort care group should consider hospice. Palliative care, they could also be on palliative care, but hospice makes sense in their situation. So that's all I want. That's all I have. I want to thank you all for listening, for being here, for showing up, for what you do in the community. Please tell people I'm here. I want to help. I encourage you all to do a couple things. One, go to my website and sign up to be on my email list, because then you'll get access to my blog posts as they come out. And then come and find me on social media. So I'm on Facebook and Instagram, and I'm also on LinkedIn. And that is my email at the very bottom there. So if you want to take a picture of it, or however you want to save my stuff.
Yeah, I'm dropping it into chat for everybody. All right. Well, once again, Dr. Lamb, great talk to get us thinking about some things that are difficult to be thinking about and talking about it. And okay, so let's see. Let's get through these questions in chat and jump in if you've got anything you'd like to share. Let's see. Michelle says, how do we prevent medical professionals from withholding options based on our care goals, or what medical professionals perceive that our care goals should be? Yeah, I think, as you said, I'm really glad you brought it up, because you got the insider's perspective. Is that a DNR, to somebody that's not been through sort of a holistic training, they may perceive that differently than you want them to interpret it.
Yeah, that's a tough question. I think the more that you can understand the medical situation that you're in, the more you'll be able to advocate for the person that you're speaking for, or for yourself. It's a hard question to answer, so generally. And so I think, if you want to talk about that with me, I think maybe just send me an email, and I can maybe guide you a bit. But the more educated and informed we are in these types of discussions, but then also in our own medical problems, and how our medical problems can be treated, that's part of it. But then also, it makes me concerned too. If you're entering the hospital system, you may not be able to choose what doctor you work with. That's true for sure. And in the emergency department, you can't pick what doctor takes care of you. Nor can you in the hospital in a lot of situations. But if you're having issues advocating, you may need a different primary care, a different specialist.
Yeah. Now, Irene's got a great comment here. And I think these discussions are, Irene, I love what you're saying. It's how can we know what medical procedures might be proposed when we're totally healthy? It's we try to create all this planning and think about every possible scenario, but how many folks do we know that they really did try their best to think about this, and then they wake up one morning and they've got this diagnosis that's totally in left field?
Yeah, there's definitely things that are common with aging. So you can learn about the medical issues that happen with aging. So stroke, heart attack, heart failure, kidney failure, kidney disease, infection, sepsis. Sepsis is a severe infection that causes organ damage. Pneumonia is huge, right? Pneumonia, if you And now there's all these reasons why you can get pneumonia. You can get pneumonia from the flu. You can get it from COVID. You can get it from bacteria. You can get it because you aspirated. You know, there's a lot. And stroke is huge. Like stroke, if I had to pick one medical problem that I would tell people to talk to their family about, it would be if someone has a devastating stroke, where they're left, you know, not able to swallow and not able to communicate.
Yeah,
That
in fact,
happens all the time.
one of our most popular discussion topics in 2022 was aphasia, and we put that together right after Bruce Willis was diagnosed with aphasia, and that's a condition that most people, stroke is most common for people to have aphasia, and a lot of unknown things about that.
Yeah, it's a very common symptom of stroke.
Ashley asked, do you think goals of care conversations happen at research hospitals like the Hopkins Cancer Centers or dementia trials? You know, one of the things I think that I like this term goals of care. I like how you frame that. So often the term about these discussions is advanced directives or advanced medical or life care plan. Like, you know, but I really think goals of care is much easier to understand. And do you know anything about the conversations that happen at research hospitals?
Not firsthand. I mean, what I see in the medical community is us telling people, like, get your affairs in order. You know, people say go see a lawyer and get your advanced directives drafted. I mean, I have a huge bone to pick with advanced directives. I've torn them apart on my blog. I could talk about how the living will is a relatively useless document, you know, all day long. And I'm actually working with a local attorney to try to improve language inside of advanced directives, so it's more focused on goals of care, because they're so vague and they don't tell us what to do. But yeah, I mean, I don't know if this type of detailed discussion is happening, because I think the thing is, it takes time. Like, it takes time to have a conversation like this. And so to do it on an individual level, I think is really, really challenging. That's why I think that we need to build this type of education for people to consume on their own time, you know, and tell them how important it is, and then point them to people who do this work.
Yeah.
More people need to do this work.
Have the conversations and then be able to go into an attorney's office with these details, so that you're not paying for more of those conversations with the attorney too. You know, I know sometimes people are apprehensive about that, is because they're sort of like, oh geez, the meter's going to be running when I go into the law office. Let's see, Carla Anderson says, I've been wondering why these issues have often been swept under the rug throughout my 40-year career. It seems like most nurses see this as a problematic and unnecessary. So thanks for your perspective there, Carla. Let's see, Rosalind says, some serious illnesses clear in time. Some help may be necessary. Communication can be creative as one gets through the illness. Think deciding on end of life may be premature. Irreversible vegetative state is more clearly final. I think I understand what Rosalind is saying there, but having conversations, I think, is key, because yeah, I mean, we all hope when we get sick or a diagnosis that this is going to be temporary, and actually that conversation that you have can be very helpful if things turn around.
Yeah, 100%. And it depends on the clinical situation, like what the odds are, what the likelihood of someone recovering, you know. And if someone's critically ill, we know that they may have a permanent impact to their quality of life. And the question is whether or not they're okay with that. And that's why when you know this, when you've had these types of talks, you can actually talk to the care team and say, hey, look, like, my person cares about quality of life, but like, are we looking at months for them to potentially get better? Are we looking at weeks? Like, they want a chance to try and live and get better. Like, you know, you can say that. And I think that's very reasonable. It just depends. It's hard sometimes to talk about these things broadly because there's so many different medical variables and then human, like individual variables. Like if someone is obese, if someone has like terribly uncontrolled diabetes, if someone has poor kidney function, like they have a higher risk of not doing as well. And so I get your point though, like you're 100% right. Like we shouldn't just like throw the towel in on people. Like I don't agree with that. But these types of conversations can help us better advocate for our people too when they want to live, you know, because I tell people all the time, like we feel like we're hurting people. We are causing them poor quality of life and suffering right now in the hospital. We know that. But like if we know that that person wants to live, then that is helpful. That is helpful for us to be able to continue to do our very challenging jobs of taking care of people who are suffering.
Great. Let's see. Karen Dotson, if folks, we're recording this and we'll record the chat, but Karen Dotson has some great links and details about Pulsed.
Oh, that's great.
Specifically to Virginia, but in general, you know, every states have different language and what they call this.
Yeah. Eventually I would like to build training for each document in every state from an ER doctor's perspective. Eventually I would like to do that. I'm going to do it for Virginia, and just put it out there, you know, to help people.
Let's see. Dixie says, as a nurse case manager, I have to be assertive and fearless when requesting hospice referrals from doctors. It is important for folks to know they can request a referral and hospice will assess you and their doctor will determine if you qualify. If you're not eligible, you will not be enrolled. No loss. Hospice care sooner than later is always better, and it extends life and quality. Less is more. And I think that's what we hear more than anything, especially in hospice. I wish that families had called us sooner. So great advice there, Dixie. And also, folks, you can see there, Capital Caring Hospice, very large and extensive resource here in the DC, Maryland, Virginia area. Let's see, Rosalind says, lifelong consequences can often be tolerated creatively. Some doctors give rash choices without offering options. Other doctors view a situation differently. Quality survival is often more possible than initially discussed.
Yeah, it just depends on the clinical situation and the person's individual risk factors. But yeah, I mean, it's amazing what human beings are very resilient, and we can survive a lot and we can adapt to a lot of things. So that's well put.
Jennifer Brown says, I understand that this is a complicated legal, political, and personal issue, but would you be willing to share where you stand on the right to die as part of an individual care plan?
Yeah, I have no problem talking about that. So, I mean, my father was diagnosed when he was 50 years old with terminal brain cancer. And I can tell you that I knew the exact moment when my dad didn't want to be alive anymore. Like I knew if I could have administered a medication, I would have done that for him. Like, because he was very direct and very frank about how he lived, and he suffered. And I think that people who are able to make informed choices and they understand that, especially in terminal cancer, I think that of course we need to look at people's mental health and make sure that that's not an issue. And when someone loses capacity to make their own medical decisions, like when they're living with dementia, that can get very complicated, like you alluded to. But if I knew that I was going to die from cancer, I would want the ability to end my life on my own terms and to do so in a safe way. So yeah, that's my opinion.
Yeah, and if if anybody in the audience is interested, Compassion and Caring, Final Exit Network, there's lots of great information out there on medical aid in dying and right to die. Okay, Margie says, I'm amazed at how many doctors do not discuss the Maryland MOLS forums with their patients. I'm often introducing the topic with my clients. I give them the form and tell them to bring it to their doctor for their next appointment. It's ridiculous when most of our clients are in their 80s and 90s. So yeah, we hear
so
that and often.
I have a family that lives in Maryland, and my cousin's grandmother, I got on Zoom and walked them through the MOLS form, and then they took it to the doctor, and the primary care doctor like wasn't really like familiar with it, and so they were almost like using what I taught them to help this doctor help them fill out this form. And those forms, from my understanding in Maryland, are mandated for people to have when they're entering medical facilities. So the hospital, dialysis centers, living facilities. Now there is an option on those forms where you can say, I don't want to fill out this form, but they're, from my understanding, they're mandated documents. So it's a lack of education. And yeah, it's a problem.
Great. Lots of great comments in chat. Because we're past the top of the hour, I'd love to read all of them, but we're making copies of this so everybody can connect. And let's see, I just want to yep, Sandra, she says goals of care is far more usable than just advanced directives. Make it plain and clear. Thank you. I've learned a lot. Just checking. Sandra's also asking, do you have a colleague in Pennsylvania that might be doing what you're doing? But I believe is your training primarily online?
Oh yeah, my training is online. It is geared towards dementia family members.
Okay.
So I built a course that includes all this goals of care stuff. And it's specifically for family members of people living with dementia. I don't know of anyone else doing this work. I hope more people do, but this is something that you can that I can do nationally. So if you want to put together training, you want to hire me to put together training, I was like, just send me an email.
Great.
I guess.
And we got through it. I can't believe we went five minutes over the hour. We don't have a time limit on these things. We just try to get through these. Dr. Lamb, once again, this was a great presentation. I commend you on your work. I love the fact that you have taken what you've seen as an emergency room physician and trying to help people be better patients, family members, and consumers of medical services. And I want to thank everybody in our audience. Once again, isn't it great, the questions that come in? I just love this. I get so energized when I see the comments and questions that you all pose on these discussions.
Yeah, thank you so much, everybody, for being here and sitting through this. I know it's not the warm and fuzzies, but it's so important. So yeah, reach out to me if you need help, and thank you so much for having me, Steve. I look forward to our next topic.
Yeah, no, okay, keep me posted, and we'll talk to everybody soon.
Okay.